Hello, everybody. So let's jump right into chapter 8. Okay. So today we're going to be talking about emergency situations that can happen in the OR and all hazards preparation as well. So after you study this chapter, you're going to be able to recognize developing emergency situations. You're going to be able to initiate appropriate action and assist in the treatment of the patient. You're going to be able to apply knowledge of radiological and chemical injuries, as well as biological warfare to the treatment of the patient. You're going to be able to discuss the various roles the surgical technologist can fulfill during an all hazards event, and then discuss the nature, human and nature human caused types of disasters. So there's different types of disasters, and we'll talk about all those. Explain the various components of personal healthcare facility and national disaster planning, and describe the initial response and steps taken when an all hazards event occurs. So what are the indications of emergency situations? So these are some of the symptoms that we're looking at in a patient that could be prior to the case. So the patient's already in the OR with you. The case has not began yet, so there's not been a first incision. And the patient could start exhibiting any of these symptoms, and that would be an emergent situation. Any difficulty breathing or chest pain. And these are things that you're going to just be taken note of as you're in and around the patient before they're put under anesthesia. Anything that you see here, and even once they're put under anesthesia, you're just part of the team that is helping monitor and look for any changes. So any changes in skin color or the vital signs. So this is not only you that's taken evaluation of the patient, everyone is going to be doing this. So the anesthesiologist is definitely going to be keeping a check on all of these things as well. But this is just things for you to know that this is what is being watched for. And so if you are the person that notices this, you want to make sure that you bring it to the attention of the providers. So open bleeding wounds or visible punctures that are not indicated on the patient's chart. If the patient has an inability to move an extremity, and that's new. Mishappen or misalignment of a body part. If they become disoriented or confused. Now, once the case is started, these are some things that are emergency situations. Rapidly dropping blood pressure, any cardiac dysrhythmias, if they become hemodynamically unstable, and that just means the combination of all of this, the cardiac rhythm, the blood pressure, the respiratory rate, the oxygen saturation, all of that. Also rapid hemorrhaging, chest pain. So these are things that cause a patient to be at risk for having cardiac arrest. In an awake patient, we're looking at chest pain if there's unstable blood pressure, tachycardia, cardiac dysrhythmias, any change in their respiratory pattern, hypovolemia, so if they start to lose too much blood, also a laryngeal spasm. All of those could put the patient at more risk. Now, a CPR, and I know you guys are going to get trained on this next in the next 2 months. So just know that this is, it does take place in the OR, and it's not uncommon. So, but CPR is the technique of manually providing chest compressions and ventilations to a patient that is in cardiac arrest. So the goal of this is to provide oxygenated blood to the brain and the vital organs, and it reverses the process that lead to death. Now, CSA, which is, SCA, which is a sudden cardiac arrest, as well as ventricular fibrillation, both of those demand CPR. There's a lot of cardiac dysrhythmias that do not, but these do. CPR needs to be started as quickly as possible. The patient only has 4 to 6 minutes before the brain cells start to deteriorate. So that time window is extremely important. So as soon as there's any notice, and you'll learn that in CPR, but we'll go over some of that today. So here are those 2 rhythms that we just talked about. This is sudden cardiac death. So this is asystole. This is a normal sinus rhythm that you'll see on a patient without any difficulties. And then this is V-fib. So this is one of the shockable ways. Here's a YouTube video. We're going to see what that says.
Homeowners, if you are tired of paying too much money for electricity and have a history of paying your...
So this patient's in sinus rhythm at the moment. Let's just keep an eye on it there. Now the patient's now gone into ventricular fibrillation. And in ventricular fibrillation there's fast, the machine's alarming to tell me, that's good, I had noticed. So in ventricular fibrillation there's fast, chaotic, uncoordinated contraction of areas of the myocardium. Different bits of the myocardium doing its own thing. It's twitching and quivering. And in this rhythm there's no effective cardiac output. The blood pressure is going to be 0. Now the causes of this can be ischemic heart disease such as myocardial infarction, severe or congenital heart disease, electrolyte imbalance, rapid changes in the levels of potassium or calcium in the blood, for example. Could be electrocution, severe hypoxia. And we notice the rhythm's irregular with poorly formed wide QRS complexes. And I would certainly classify this as a coarse ventricular fibrillation. But because we're not treating it, it'll become finer over time. We'll get a finer ventricular fibrillation. So now we can see it's becoming finer. It's not as, the amplitude is less than it was. And the finer ventricular fibrillation is harder to treat. So we can see it's much finer now. And the longer we don't treat this, the finer it will tend to become. The finer it is, the more difficult it is to respond to defibrillation. This version is quite a lot coarser now, so it should respond to defibrillation more readily. Patient, of course, in ventricular fibrillation is going to be very rapidly unconscious, no pulses, agonal or no respirations. As a first aid treatment, we would have to give CPR, but then the treatment for fibrillation is electrical defibrillation. Now this rhythm is a ventricular tachycardia, VT, very rapid ventricular contraction, but with a degree of coordination. Now this is quite a severe ventricular tachycardia, and this patient will probably be unconscious. But in some ventricular tachycardias, the patient can remain conscious for periods of time, indeed hours, although they'll feel very unwell. And if we don't treat this condition, this ventricular tachycardia, it will become a ventricular fibrillation as the rhythm gets finer. And we have to treat this with defibrillation. It's one of the shockable rhythms. So there's only two shockable rhythms. There's ventricular fibrillation and this one, which is ventricular tachycardia. If the patient's not unconscious, we have to, of course, anaesthetise them prior to administering the shock. Now this patient is in asystolic cardiac arrest. There is no systolic contraction at all. The ventricles and indeed the atria are not moving. And asystole, A means without. And of course this is the rhythm that you would get with anyone who was dead. But if someone's gone into this rhythm recently, we would try to reverse it by inducing a shockable rhythm such as ventricular fibrillation. So that's asystolic cardiac arrest. Now there's another type of cardiac arrest called pulseless electrical activity. And that's exactly what it says. There is no pulse, but there is still electrical activity going on in the heart. And the waveform of that electrical activity can vary quite a bit, but it could look something like this, almost like a normal, in this case, sinus bradycardia. But the key thing is there is no kinetic movement of the heart. So the depolarization of the ventricular and atrial myocardium is going on as normal, but the heart muscle is unable to respond to that. So we would need to try and correct the underlying causes of this. And indeed that's true with any cardiac arrest. We need to try and correct the underlying causes. And this is where the 5 H's and the 5 T's come in as causes of cardiac arrest that we can use to prevent cardiac arrest, but we can also use it to try and revert a patient who's in cardiac arrest. And the 5 H's as causes of cardiac arrest are hypoxia, not enough oxygen getting to the myocardium; hypovolemia, not enough blood getting to the myocardium; hypothermia, when the body temperature is too low; hypo or hyperkalemia, both can cause cardiac arrest, whether the potassium is too low or too high. And the 5th H is hydrogen ions, which of course is the cause of acidosis. So if there's more hydrogen ions, the pH will be lower because the patient will be more acidotic. And then the 5 T's as causes of cardiac arrest. One is tension pneumothorax, where there's a build-up of pressure in the pleural space. Cardiac tamponade, T for tamponade, where there's increasing pressure within the pericardial sac, constricting the heart. T for toxins and potential drugs, of course. And then T for thrombosis, which can be pulmonary thrombosis. And T for thrombosis, which can be coronary thrombosis. So this shows the importance of not just looking at the monitor, but assessing the patient's overall condition and palpating central and as well as possibly peripheral pulses.
Okay. All right, so that helps you understand a little bit more about how you're going to be seeing different reactions to different cardiac rhythms. So the first priorities. So these are the way that you're going to look at things. Patient airway and circulation status is number one. In emergency situations, of course, priorities are going to be in this order, where chest injuries are going to be first, shock is next, wound protection and closure, fractures, vital sign monitoring, and then, of course, reassuring and comforting the patient. Now, symptoms that could indicate the patient is having a cardiac arrest is chest pain, of course, in the awake patient, unstable blood pressure, tachycardia. So the heart begins to try to compensate. Those dysarrhythmias we just started seeing, respiratory changes, hypovolemia, not enough volume, and then the laryngeal spasm. So the larynx starting to spasm around the ET tube if that is in place yet. Oops, let's see what just happened there. Let's go back. And then there is a chain of survival. This is dependent on the order of how you do things. And the old method is ABCs, with airway being first, so providing breath and circulation. So this has been changed, and I'll go over that, but this was the older way of ABCs, airway, breathing, circulation. So you check the airway, make sure that it's open, then you would check the to see if there was any breath, and then checking circulation, so checking for a pulse. And then D is the definitive treatment. So what is causing the lack of airway, breath, or circulation to be occurring? And the requirements for successful resuscitation, of course, first of all, it's that early recognition, because remember, we only got 4 to 6 minutes. And then activating trained responders as soon as possible, and going ahead and beginning CPR while you're waiting on trained responders. That's why everybody is trained in CPR in the healthcare field. Every staff member is trained in CPR so that can be initiated while waiting on trained responders. Early defibrillation, most facilities have a defibrillator in easy access. And so during CPR, you will be trained on how to use a defibrillator. Then there is an advanced course that can be taken, and it is advanced cardiac life support, so ACLS. All your nurses will have ACLS, all your physicians will have ACLS, and then a lot more support staff can take ACLS if they so choose. It's offered at the hospitals. Most of the time for employees, it is free of charge, but it depends on the facility. So starting advanced cardiac life support early does help as well. And this would be initiating medications that will help the heart in the resuscitation process. Now, that change that I mentioned has occurred, where that now the chain of survival is now the CAB. So circulation is first now, and then we can check airway and breathing. So now the chain of survival is recognizing cardiac arrest, activating the emergency response system, beginning early CPR, defibrillation, and effective ACLS. And then, of course, after it's completed and the patient is now resuscitated, integrating post-cardiac arrest care is just as important. Now, in the past, look, listen, and feel was part of CPR, and that has been eliminated because one, it was very time consuming. Two, it was challenging to ensure that it was done correctly. So that has been eliminated from the recent CPR trainings. So if you were trained in CPR in the past, you may be wondering why they're no longer teaching look, listen, and feel. And so the 2010 guidelines made the changes of circulation first. And so if they're unresponsive and there's no breathing, and even if there's abnormal gasping or agonal breathing, I'm going to show you what that looks like. You're no longer going to shake the patient, but you're rather going to tap them on the shoulder, because shaking the patient could increase the risk of a cervical spine injury if that was the contact that was made if there was an injury. And then now the ratio of chest compression to breaths is 30-2. So the motto is push hard, push fast. And it's a rate of 100 times per minute and with a depth of 2 inches. It used to be 1.5 inches to 2 inches, and now it's 2 inches. Now we also use head tilt chin lift to open the airway, and you'll learn all of that in CPR class, but it's just to kind of get you started thinking along that line. So here is a video to help you see what gasping or agonal breathing looks like. And this is highly indicating that cardiac arrest is occurring.
Gasping or agonal breathing is not true breathing. Do not confuse it with normal breathing. The victim is in cardiac arrest. There may be seizures. The intervals between breaths get increasingly longer. Start CPR immediately as if the person was not breathing.
So as you can see, it is not a supportive breath pattern. And so you can see why CPR needs to go ahead and be initiated at that point. It is not enough to sustain life. In the surgical setting, things are going to be different than if you're out away from the hospital when something like this happens, because they're going to be able to control any dysrhythmias by cardiac defibrillation. They'll have one there in the room. The anesthesiologist will be using IV drugs, and there will be post-resuscitation care that will be put in place. They'll be easily monitoring blood pressure and blood gases as well. Artificial respiration, so that's called bagging a patient. And I've got a picture of that for you in a moment. That will be provided. And IV access is already done. Arterial pressure is easy to gain. And then, like I said, the blood gas monitoring, airway management, respiratory and cardiac support is all easily or done in the surgical setting much more easy than away from that setting. Here's some things that you may be requested to do. First of all, you're going to be protecting the sterile field, and then you may be requested to bag a patient. So here you can see this would be that role. You'll learn how to do this in CPR class. So pay close attention to this because you may be requested to do the bagging or chest compressions. You can see how this person is up on the bedside, and often that is the case. If not, there will be a stool beside. It just depends on the table height, and if it is, if it's at the lowest setting possible and it's still too high, even with a stool, this posture is not only accepted, but it's also expected, because you've got to be able to be up over the patient and be able to put that pressure. And you'll learn in CPR class, you're learning kneeling on the floor beside the patient. And so when you're on the bedside with a patient doing CPR, it feels the same as when you learned how to do it, kneeling beside the patient. So make sure that you're comfortable doing both of these in CPR class, because these are two of the tasks that you can definitely be asked to perform during resuscitation. Malignant hyperthermia. So this is a situation when there is life-threatening excessive body heat. There's an increase in body temperature. It is usually an acute pharmacogenic disorder, so something that one of the anesthesia agents will trigger, and it can happen during or after anesthesia. And what you'll see is a really rapid increase in body temperature, unexplained tachycardia, so really increased heart rate, unstable blood pressure, and it could be high or low, and then muscle rigidity, as well as increased heart rate, or increased respiratory rate, so tachypnea, and then cyanosis. You may notice that they're looking blue, and muscles are rigid, and they're breathing fast, and their heart rate's fast, and their blood pressure is unstable, and their temperature's fast. So this is malignant hyperthermia. Another condition is called disseminated intravascular coagulation, and you'll know this as DIC. This is a pathological process that happens in the body, and what happens is everything begins to coagulate. So all the blood starts to coagulate, and so then we have a lot of clotting symptoms happening. And then what happens is it clots so much that it depletes all of the clotting factors, and then the patient starts to bleed out, basically. And I've seen this happen, and to the severity that the patient was bleeding from every orifice, including the eyes, the ears, the nose, the mouth. Everything was bleeding because there was no clotting factors at this point. What can stimulate this condition is typically it's an infection of the blood by bacteria or fungus. It can also occur with tissue trauma, so like a head injury, a shock, burn, leukemia or cancer can cause it, severe liver disease, if they've had a recent blood transfusion and they had a reaction to that. And then a lot of times in OB, some of the complications can lead to DIC. So the primary one that you see the most of the time is the infection. And here are some images of what DIC could look like. So this is of the arm. So this is bleeding in the tissues because there is no coagulation. You can see here it's a lot of speckling. And here's another image of the leg. Here's on the ankle. So this is a very mild one, of course, in this. And it goes from upper right-hand corner is probably the most mild form. Upper left-hand corner is next. Lower left-hand corner would be more severe. And lower right-hand corner is extremely severe. And this patient is probably extremely ill. Now, anaphylactic reaction is another thing that you want to be aware of. The characteristics of this, there's going to be a exaggerated allergic reaction to any substance or protein. The things that most commonly cause these reactions are drugs. Local anesthetics can cause it, codeine, antibiotics, animal-derived products like insulin. Contrast media is a really common reaction agent. And in some cases, the latex found in surgical supplies. And if you guys remember, we talked about how we would manage a patient with a latex allergy. We would do them first case of the day. And now the goal for these patients, as you can see in this picture, with the swelling that's occurring in the face, you can assume that that is occurring in the airway as well. So maintaining the airway is number one, and then preventing the cardiovascular from collapsing and going into shock. So you want to be able to maintain that airway so you can get oxygen in immediately. First line of treatment is going to be epinephrine to try to reduce that, and steroids to try to reduce the inflammation. And then all hazards preparation. So this is many different types of emergencies. It could be something outside of a hospital, including things happen in the local community, the county, state, or even on a federal level. And as we've all known in the last couple of years, COVID has been kind of one of those all hazards preparation in many situations where the facilities were overrun and the entire facility's procedures had to shift. And so emergency preparedness is an action that is taken by not only individuals, but the governments, healthcare facilities, allied health professionals, and the systems. This is ways to be prepared for any type of emergency, and your facility will have that. You'll go through orientation to understand what that entails and how you play a role in that. Natural disasters, of course, this is the most common kind of disaster that affects large populations. And those can include rock and landslides, cold and heat, earthquakes, tsunamis, tropical storms, and hurricanes. And I had your terms written down. Let me find that. Because I remember now one of them was about hurricanes. I had written that down. Oh, I think. So we're gonna, a key term that I want you to remember is gonna be sustained winds. And so sustained winds in a hurricane situation is that is how that they are categorized. So when tropical storms and hurricanes are being, they'll say it's a Cat 5 or Cat 3, that is determined by the sustained wind speed. So sustained wind is your first one. And then I will get you the next two. Okay. And then man-made disasters. So this could be like Fukushima, when the radiation spill occurred. So chemical and radiation release, explosions that happen, infrastructure incidents, such as years ago, there was a interstate that collapsed. And so that was a major man-made disaster. Transportation accidents, again, that could be in those, that could be a bridge collapsing. Terrorism, bioterrorism, 9/11 is the primary example of this. Biological agents, we had a scare with anthrax years ago. So things of that type. Personal disaster planning. So this is important that you and your family have preparation steps in place. So you want to research and identify, as well as familiarize yourself and your family with local and regional emergencies that could occur. So knowing where you are and know what could occur. So when I was in the Pacific Northwest, I always knew that earthquakes was a possible emergency. Now that I'm in North Carolina, I know tropical storms and hurricanes are more, tornadoes are more of what I would see. And so creating a family emergency plan for each type of emergency is very important, including water, radio, emergency supplies, things of that nature. So you want to prepare what's called a go bag, and as well as in-home supplies. So what we have is we have a bright red backpack. That is our go bag. And then we have in-home supplies that are just in home, so emergency supplies we'll find under the bathroom counter, as well as, looking at making sure you have excess water supply on hand for the amount of people that are going to be in the home or that have to leave the home. And then have an emergency contact information, because these days everybody's information is plugged into your cell phone and you can't remember anyone's phone number. So you want to have something written within your go bag so that you have those emergency contacts, that if you're having to use someone's landline or a payphone or something, that you are able to know those phone numbers. So your second term is going to be go bag, and so that we know we need that emergency bag ready. Okay, and then responding to disaster situation. So these are divided in local and federal responses. And we know that we have FEMA, everybody's familiar with FEMA. What we also have in the local responses, we have LEMA, which is the local emergency management agency, as well as the National Incident Management System. And then there's, in every area, there's an incident command center or command system. And so if you're plugged into your community, this is something to be familiar with, and it allows you to be of service when that occurs. Also, as a healthcare provider, you're able to get on the database with FEMA, that if your services are needed, you're willing to go. I know that I've received those notifications on many occasions of things that are needed in different areas in the US when there are disasters that are occurring. So the federal emergency response system, this entails federal assistance and that has to be requested through those formal channels by local and state governments. And of course, it can take up to 3 days or even longer to get that assistance response. And then, of course, there's tons of forms, agencies and assistance forms. And as I mentioned, FEMA is a big agency that allows help to come as quickly as possible. Then, of course, we have a national response framework and the National Disaster Medical System. And this one is more in the line of who is contacting when there's an emergency if your help is needed. And then each healthcare facility is also going to have an emergency response. They'll have an EAP, so an emergency action plan, and that's going to follow state and federal regulations. It is required by Joint Commission to have that. You will be trained on that in your orientation, as well as there's usually some types of drills that are in place just to make sure that you are familiar with how that works. And the plan includes mitigation. It also includes preparation, preparedness, response, and recovery. So it's really about mitigation is looking at what are the dangers in that local area, like what all could happen. So it's looking at all the situations that could occur in a given area, whether you're close to a nuclear power plant or whether you're close to a coastal area or whether you're on a fault line, or all of these things that are taken into consideration to figure out what are the risks and how can we lower the risk, and then how can we be prepared for those risks. So then that moves into the preparedness, and then how are we going to respond, and then how are we going to recover. So all of those components are taken into account when these EAPs are developed. Of course, a hospital has a hospital incident command system, and each healthcare provider has responsibilities within that system. And so one of the primary ones is to evacuate all the patients. You're going to move them to an area of the facility that's the most safe and secure, and that will be designated at the beginning of the action of the plan of like what area is the one that's the most that can be the most secure in certain situations. Of course, there's a lot of logistic factors as far as how many people there are, patient-wise and staff, food and water, safety, and all of that. And then saving, protecting, and transporting of medical records is utmost importance. It is a little more clear-cut these days because most facilities now use digital medical records. And so it's not like it was years ago when there was a risk of losing the medical records to flood or fire or tornadoes or things of that nature. And then some things that are important to consider when you're in this event is you want to make sure that the disaster scene is safe before you enter, because if you are unsafe, then you're not going to be able to serve anyone else. Also, taking standard precautions and using your personal protective equipment is very important to continue to maintain your own safety. And then identifying the patient decontamination area, and then triaging victims. And so this is a table in your book that is going to walk you through the DIME of how to triage these patients. And so it takes you from a green tag patient, which is a patient's basically okay, they're stable or minor injuries, to yellow and they're a little more severe, but they're still stable. A red tag, meaning they're severe, they need seen first, and a black tag, which means their chances of surviving are slim to none, and they are put in an area to just try to make them comfortable. And then, of course, the risk communication with the public. So, the public will be communicated with through the facility, and also about making sure that any risk that any harm that they could be in is communicated as well. And then, of course, there is a lot of moral, ethical, and legal issues that are associated with the providing care during a disaster. And the main thing is to do the best that you can, keep yourself safe, and then do the best that you can in providing care for the patients and keeping them safe. There is a emergency system for advanced registration of volunteer health professionals, and this is the one I was talking about, and the community emergent response team. So both of these are those organizations that allow you to register ahead of time to be called out when there's any kind of emergency. All right, and so in this chapter, you have learned the indicators of emergency situations. We've looked at different disaster types. You've looked at components of your personal, your healthcare facility, and national disaster planning. And, looking at your own personal planning, this is going to be your third keynote, knowing, and it's just letting me know that that someone that plans their personal emergency, has a personal emergency plan, it's easier for them to implement a facility's emergency plan because they've already got that mindset going and they kind of understand how they're doing it themselves. And then we looked at the all hazards event to consider. All right, we are going to, let me stop my share real quick. And then I'm going to queue up a video for you, and we're going to watch one of the lab videos. Let me get it queued up in a minute. And I know that we watch these over and over, but I'm telling you, it's going to help you remember things. We are going to work on, let's see, we did that one last week. Let's look at back table. We're coming into the end of this term. So let's see, we've got these. Let's go ahead and look at positioning the patient this week.
Positioning the patient is an important preoperative responsibility of the surgical technologist. The purpose of proper positioning is to provide the best possible access and visualization of the surgical site while causing the least possible compromise in the physiological function and stress to joints, skin, and other body parts. Positioning should also provide access to the patient for the administration of IV fluids and anesthetic agents and provide for patient safety. Safe positioning of the surgical patient is imperative for successful surgery and is the responsibility of the entire surgical team. Positioning the patient requires knowledge of the procedure to be performed and any special needs the patient may require. When a patient is awake, physical indicators such as pain and pressure that warn when the limits of stretching and twisting are being reached maintain the range of motion of the body. Muscle tone also helps prevent strain and stress to muscle groups. Under anesthesia, these protective devices are no longer active. After anesthetic agents have been administered, the patient is completely relaxed and paralyzed and has no ability to react to movements that could potentially damage joints or stress muscle groups. This is especially important to note with the arthritic patient, who may have joint changes that will prevent even the slightest movement beyond normal range of motion. For these reasons, it is important to avoid extreme exaggerated positioning for extended periods of time. Patients are at higher risk in a long surgical procedure and during vascular surgery, where blood perfusion may be low or even interrupted. Patients with demineralizing bone diseases, such as osteoporosis, are also at increased risk for injury. For these reasons, it is important to always use the correct padding and support. Also, when moving the legs, both extremities should be moved slowly and simultaneously, as this helps prevent muscle injury. The supine position is the most natural position for the body at rest. Body regions that may be accessed with the patient in the supine position include anterior lower extremities, pelvis, abdomen, chest, breast, shoulder, head and neck, and the upper extremities.
Begin by gently lying the patient flat on their back. Place and secure the safety strap over the patient's mid-thigh or mid-abdomen with the patient's arms along the body's side, palms facing the thighs. Next, pad the patient's arms with egg crates or gel pads and tuck the draw sheet around the arms to secure them. Place the patient's legs straight and parallel, in line with the head and spine, with toes pointed toward the ceiling. Pad the heels with gel pads.
We all know that CPR saves
Patient's
lives,
legs should not
but
be
to
crossed.
perform effective CPR, it requires a
Finally,
highly organized
make sure
team
the head
with
is
clear
faced
roles and
toward the ceiling,
responsibilities.
and
As
then
we watch
rest
this
it on the
video
head
filmed at the Ochsner Simulation Center, pay attention to how the roles shift as the patient
cradle in order to prevent extreme rotation of the head intraoperatively and to prevent possible occlusion of the vertebral artery. Modifications to the supine position may be used depending on the requirements of a particular procedure. For example, certain procedures may require the position to be modified by extending the arms on arm boards. To avoid hyperextension injuries, the arms should not be extended at more than 90 degrees to the body to prevent hyperextension of the shoulder.
Watch this scene carefully. What are some examples of improper technique used in this scene? Did you catch these important errors? The safety strap was not properly secured. The surgical technologist neglected to pad the patient's heels. The patient's arms were extended at an angle greater than 90 degrees, and the patient's legs were crossed. Typically, the patient is placed in the supine or dorsal recumbent position prior to the administration of anesthesia. The patient may remain in the supine position for the procedure or be repositioned as needed once anesthetized. Any additional procedures, such as application of anti-embolytic stockings, insertion of a Foley catheter, or application insertion of additional monitoring devices are performed prior to repositioning. Once the patient is anesthetized, permission must be sought from the anesthesia provider to reposition the patient. The anesthesia provider usually assumes the leadership role in positioning the anesthetized patient, since they are responsible for maintaining the patient's airway. The surgeon may also have additional preferences for final positioning.
One of the first things we teach is anatomical position. So when we do positioning with patients or each other to practice on, we really stress to keep the body in a neutral position, nothing abnormal. We don't want the arms extended further than what they would naturally. We want to make sure that there's a lot of padding under our patients because they don't have the reflexes anymore when they're under anesthesia to protect themselves, and we need to protect them.
The reverse Trendelenburg position is another modification of the supine position where a padded footboard is added to the operating table and the patient is tilted foot downward.
Begin with the patient in the supine position. Apply the safety strap snugly, approximately 2 inches distal to the knees. Then apply a padded footboard to the operating table. Secure permission to move the patient. At this point, the operating table should be tilted foot downward to approximately 45 degrees or the desired angle. This position provides access for upper abdominal and thoracic procedures. Additional benefits of reverse Trendelenburg are that blood flow to the upper body is reduced, venous drainage is promoted, and respiration is facilitated.
Fowler's position is a modification of the supine position where the leg section of the table is lowered and the body section is elevated. Body regions that may be accessed with the patient in the Fowler's and sitting positions include breast, head and neck, and the shoulder.
Begin with the patient in the supine position. Secure the safety strap over the mid-thigh and secure the patient's arms onto padded arm boards. Pad the heels and place a padded footboard at the foot of the table. Check that the patient's head is forward and resting on a head cradle. Position the patient's buttocks at the flex of the OR table. Put the OR table in slight Trendelenburg position. Then flex the OR bed upward at approximately 45 degrees and flex the knee portion down. Fowler's position provides improved access to the surgical sites, such as upper shoulder and the head and neck. It also provides reduced blood flow to the upper body, promotes venous drainage, and facilitates respiration. Air embolism, however, is a potential concern when the patient is in the Fowler's position. The sitting position is a modification of Fowler's position, where the torso is placed in an upright position. Padding under the heels is especially important to prevent sciatic nerve damage. The flexed arms are then placed on a lap pillow or adjustable table. The patient should always be returned slowly from the operative position back to the supine position. This allows the cardiovascular system time to adjust.
Patients with cardiovascular conditions and the elderly are at particular risk and should be carefully monitored. Also, respect for the patient as an individual should be maintained at all times, and covering for modesty should be continued even after induction.
Respecting patients' privacy and their personal dignity is very important in the operating room. It can be a struggle because depending on the positions we're putting our patients in, and moving them from the table to the OR bed and vice versa. Sometimes gowns and things slip, but we try and, if it's not an abdominal procedure, allow them to wear their underwear. That gives them some sort of sense of privacy, you know, they're not exposed. We try and let them wear their socks into the operating room. Sometimes their feet get cold and it's just a little personal touch.
Even though patients are unconscious, under general anesthesia, that doesn't mean that they want their whole body on display. So it's very important to keep, blinds covered, keep the patient covered as much as possible. And also for warmth, it's not just modesty, but it helps keep the patient at a normal temperature, which can be very difficult in the OR.
The lithotomy position is a modification of the supine position. This position can be used for urological, gynecological, and general surgical procedures. Body regions that may be accessed with the patient in the lithotomy position include the perineum anus, rectum, vagina, and the urethra.
Begin by removing the head attachment of the OR table and securing it to the foot of the table. Then position the mattress and draw sheet. Next, place the patient in the supine position, putting their hips and buttocks at the table break. Uncross the patient's feet if necessary. Place and secure the safety strap over the patient's mid-abdomen. Then place the patient's arms at their sides with their palms facing their thighs or on arm boards if possible. Pad the arms with an egg crate and place the head in a head cradle. Place sockets and stirrups on each side of the OR table. Two people are needed to place the patient's legs in the stirrups. Raise the patient's legs simultaneously and place them in the stirrups. Do not hyperflex, invert, or evert the legs. Secure each leg in the stirrup. Finally, remove the head attachment from the end of the table and lower the foot of the table.
Watch this scene carefully. What are some examples of improper technique used in this scene? Did you catch these important errors? The OR team members did not apply the safety strap. The foot of the bed was lowered before the legs were placed in stirrups. The legs were placed in stirrups one at a time, and the patient's legs were hyperflexed toward their head.
Lithotomy can be difficult, getting the legs up in unison so that everything's padded and the legs are even. One's not up higher than the other and they're not just sprawling.
In prone position, the patient lies flat on their stomach with padding placed underneath their ankles, knees, elbows, arms, and head. This position can be used for orthopedic, neurosurgery, and colorectal procedures. Prior to placement in the prone position, the patient is anesthetized on the gurney or another operating table. A minimum of 4 non-sterile team members are required to place the patient in the prone position. All preoperative procedures, such as Foley catheter insertion, must be performed prior to placement of the patient in the prone position. Body regions that may be accessed with the patient in the prone position include the posterior lower extremities, dorsal body surfaces, spine, and the posterior cranium.
Begin by patting the OR table with egg crate or pillows where the patient's knees and ankles will rest. Then place chest rolls and padded headrest on the OR table. After induction, a minimum of 4 people are required to roll the patient onto the OR table once permission is granted to move the patient. The patient's arms should be positioned alongside the body prior to movement. One person is on the opposite side of the OR table, furthermost from the gurney. This person receives the patient as they are rolled onto their abdomen. Take care to ensure that genitalia and breasts are free from the patient's body weight. Check chest rolls to ensure proper placement. Secure and pad arms at the patient's sides with the palms pointing toward their thighs, or carefully place on arm boards with the palms facing downward. Finally, position the patient's head to the side.
This model represents the jackknife Kraske position. Bear in mind that padding on bony prominences is required for correct positioning. The Kraske jackknife position is a modification of the prone position. In it, the bed is flexed in the middle, with the head and feet pointing downwards. Body regions that may be accessed with the patient in the prone position include the anus and pilonidal area.
Begin by placing the patient in the prone position. Be sure the patient's hips are positioned at the table break. Add padding under the patient's knees and ankles. Then flex the operating table to the desired angle and tilt the operating table head downward to elevate the hips. Finally, apply the safety strap proximal to the knees.
Watch this scene. What are some examples of improper technique used in this scene? catch these important errors? The patient's arm was improperly secured, allowing it to hang from the table. There was no padding under the patient's knees and ankles. There were also no chest rolls, so the patient's breasts were crushed by her body weight.
Positioning with, a muscle or nerve just pinched in the right way, the patient's going to wake up with numbness and tingling in an area, and they're going to have a lot of complaints for their surgeon. And that can actually be difficult to track back and say, well, why would their leg hurt when we worked on their abdomen? Well, because, someone didn't position them just right.
The lateral position is also referred to as the lateral recumbent or lateral decubitus position. The patient in the right lateral position is placed on the operating table with their right side downward, exposing the left side of the body. The patient in the left lateral position is placed on the operating table with the left side downward, exposing the right side of the body. Body regions that may be accessed with the patient in the lateral position include the retroperitoneal space, hip, and the thorax and shoulder. Thus, this position is used for urological, orthopedics, general, and cardiothoracic specialty procedures.
All preoperative procedures, such as Foley catheter insertion, must be performed prior to placement in the lateral position. Begin by placing the beanbag on the OR table with the draw sheet on top of it. Then position the patient in the supine position. Make sure positioning devices such as pillows, padding, and suction are accessible. A minimum of 4 people are required for positioning after the anesthesia provider gives permission to position the patient. Two people grasp the draw sheet and move the patient to one side of the OR table, while another positions the lower extremities, and the anesthesia provider protects the head and airway. Next, place an axillary roll in the axilla of the non-operative side and roll the patient to their non-operative side. Place padding under all bony prominence and place the pillow between the patient's knees. Then flex the patient's lower leg. The upper leg remains straight. Hold the beanbag in place as suction is applied and ensure external genitalia and breasts are not crushed during this process. Finally, place and secure the safety strap over the patient's hips and place a pillow or other positioning device between the patient's arms.
Lateral can be very difficult because you've got to move the patient from the litter over to the bed and turn them sideways. You've got to make sure that their arms aren't falling, their legs are properly positioned and padded.
Teamwork is vital when it comes to patient positioning, when it comes to surgical instrumentation. If you don't have enough people to position a patient could get injured because you're not moving them as a unit. You don't have enough support, they could fall, an arm could be mispositioned during the transfer.
Positioning the patient is an important duty of the entire OR team. Providing healthcare is gratifying work. However, it comes with great responsibility. Knowing and practicing proper positioning technique helps you provide safe, quality care for the patient, helping you achieve the ultimate goal of your job.
Okay, so that video on positioning should be super helpful for you as you continue through this program and are able to use that information in the lab setting as well. So I want you to give me the 3 keywords: sustained WANs, go bag, and personal emergency action plan. And then also tell me either what you learned brand new from the video. So if it was your first time, what you learned that was like maybe the most interesting, or something that you didn't notice the times before when you've seen this video and then it stood out to you this time. So just let me know that. Let me know if you have any questions regarding this material, and I will get this loaded as soon as it is converted. Thanks a lot. See you guys next week.